But going on to this TAILOR-X, this trial is both exciting and somewhat problematic. The National Cancer Institute said this molecular test is really growing in popularity. CMS is paying for this. We should find out really how good it is in a prospective randomized way. So they funded a trial that I believe is ECOG administered that would look at it prospectively in a randomized patient population where the Oncotype test was being given to some patients and not to others. And based on the results, they would decide to use hormone therapy alone in the intermediate range, randomly assigned to hormone therapy alone, or combine it with chemo, and with the high risk always get chemo plus hormonal therapy with disease-free survival as the endpoint. It's going to be a while before we know whether TAILOR-X is a positive trial, that getting the test is going to get a better outcome for the patients. That while could be as many as 3 and possibly as many as 7 or 8 more years before we have enough events to be able to make any sense out of the data. So during that time, Oncotype will, of course, attempt to sell as many of its tests as it can. If the trial is positive, I think it becomes standard of practice. That likely, with a positive NCI-sponsored trial, it'd be hard to say a node-negative, ER-positive patient shouldn't get Oncotype. If it's a negative trial, it could really hurt the test. It probably wouldn't go away because it's pretty good still at the low and the high end, but then it would be sure that the intermediate end just doesn't give you any information, and it would inhibit it. The other problem is changing the recurrence score assay levels. In practice, it's 18 is the low end cutoff. In the trial, it's 10. And I think that makes a lot of issues. How are we going to make sense out of this trial, which uses the test in a different way than it's used in general practice? But we'll wait and see whether we get a positive TAILOR-X trial. At the same time, we have MammaPrint that comes forward using a completely different platform. Not an RT-PCR from paraffin-based tissue, but a gene array using the Agilent system from fresh RNA, either taken and frozen or put into an RNA-friendly fluid and transported for testing. They've just opened up US-based testing in a CLIA-certified laboratory in California to start competing. Now, what's different is, firstly, they're looking at 70 genes rather than 21. Secondly, they have a dichotomous test result, not a continuous variable. So there's no intermediate zone with the MammaPrint. It's either positive or negative. It has its own clinical trial called the MIND-ACT trial. I'll jump right to it. And this one is Europe-based, slightly different than the TAILOR-X trial in its design, but essentially trying to do the same thing, to show that the patient population that gets randomized to get a molecular test will have a better overall outcome than the patient randomized to get the usual clinical pathologic variables deciding whether to give chemotherapy or just hormonal therapy. And we'll wait to see. If MIND-ACT is positive and TAILOR-X is negative, that's going to give MammaPrint a great a head start. The fact that it did go through the FDA clearance process at the 510K level would also give it an advantage in theory over the Oncotype, which has to date not been submitted to the FDA. It's going to be an interest. It's going to take years. They'll fight against each other without data for the next 3 or 4 years, and then the 2 trials will come out with data. And if both of them are negative, they'll both be heard. If both of them are positive, it won't answer the question. And if one is positive and the other is negative, that one's going to have a big, big advantage. One question's asked to me all the time. What would happen if it's MammaPrint that wins? Its trial is positive, the Oncotype is negative, and now medical oncologists have come and said, we need RNA-friendly breast tissue in order to get MammaPrint done. And Oncotype would say, not possible in the US. It's a paraffin world. Breast tumors are put immediately into formalin, they go right into paraffin, there's no chance to get an RNA from fresh. And that's absolutely bogus. If that's the better test, we in the pathology world will work with surgery and radiologists who biopsy breast tumors and find a way to create a RNA-friendly tissue sample that can get MammaPrint done. Because the oncologists we work with will tell us if you can't do it, we'll send those breast specimens to a lab that can. So we will adapt. Will it be easy? No. Is it preferable? Possibly not. But I do not personally think that the requirement of having fresh tissue that hasn't had paraffin and formalin would ruin the chances in the United States for MammaPrint to be successful. I think if it's a better test, we'll have to make a specimen that will be ready for it. Good. And I made a comparison, a slide here, and it just covers up everything that I've said. And I talk again, the FDA term for MammaPrint is cleared, not approved, because it's at the 510K level, not the pre-market approval level. And here's the comparison of the two trials. Just look at the bottom box there. The trial design for Oncotype is which patients with intermediate risk will respond to chemotherapy. But for MammaPrint's MindAct trial, it's which patient will have an excellent outcome without chemotherapy. So the statistical design is slightly different in terms of asking a clinical question. But really, they're pretty similar. I mean, one's going to be positive, it's going to have an advantage. If the other one's not positive, it's going to have a disadvantage.